I'd like to introduce the first speaker, Dr. Jeff Zaltsman. Dr. Zaltsman is the Educational Director of Nephrology at St. Michael's Hospital, where he practices. He's also the Medical Director of the Diabetes Comprehensive Program at St. Mike's. In addition to the Chief Medical Officer of Transplant Trillion Gift of Life, he currently chairs the CST Kidney Working Group. And so without further ado, we ask Jeff to talk to us about advances in organ donation. Thank you, Jeff.
Thanks, Mike. It's a pleasure to be here, and I thank the organizing committee for inviting me. I want to say that it's really a pleasure as a transplant physician to see the transformational change in critical care in this country. There is a handful of doctors who are always engaged in this, but now it's become fabric of critical care medicine, so it really is lovely to see this. So my objectives today are to talk a little bit about DCD in Canada. Does DCD impact donation after brain death? And then the focus of this talk is some outcomes from DCD donors, and it'll be local experience. So I don't know if you've seen this slide before, but it looks at the organ donation rate in Canada over the last 15 years or so. And one can see that thankfully it's grown. We're nowhere near our Spanish colleagues, but we have grown. And a lot of this, of course, has come because of donation after cardiac death. And our donation rate in Canada is now at about 18 per million. And last year we had a record number of deceased donors, of which 21% were from DCD. So we've actually surpassed the United States. And then remember, in Canada, an organ donor is only counted if an organ is transplanted. I don't know if that's the case in Spain, but in the United States, an organ donor is counted as someone who donates an organ, but about 15% of organ donors counted in the US do not result in transplants. So we do count it differently in Canada. I think most people probably know that. So this is a summary of DCD activity up until the calendar year of 2015. And at that time, we started DCD late in 2006. And at that time, there were 637 donors. And you can see the various provinces. Most provinces were partaking, with the exception of PEI, Newfoundland, and New Brunswick. Since 2016, in fact, there has been DCD activity in Manitoba and in Calgary. Prior to that, there had not been any. So for the most part, with the exception of a couple of provinces, everybody is on board with DCD. And this is just a board from Canadian Blood Services. I thank them for these embargoed slides, but I'm showing to you anyway. Looking at DCD rates per million by provinces, and as again, Manitoba has now started DCD as of 2016. And you can see that, of course, there are some provinces where DCD has been quite successful as a percentage: BC, Quebec, Ontario, and Nova Scotia. Focusing in Ontario, which is where I come from, we had a record year for organ donation last year. There was 269 deceased donors, of which 84, or 31% of them were actually DCD. And that gave us a donor rate of about 20 per million. This year, as of the end of October, we already had 295 deceased donors and are on track for, I don't want to be too optimistic, 340 donors, and there's been already 90 DCD. The organ donation rate for Ontario is projected to be 25 per million this year, which really would be an amazing year. And everybody is busy, the transplant programs, Trillium for sure, and all the surgical colleagues. If we look at the DCD transplants from just in Ontario, from when DCD started in June of 2006 till September, so this is not complete data, you can see that there's been over 1,100 DCD organ transplants in Ontario. The vast majority of them are kidney, but a substantial amount of liver. The lung program has been very, very active in Ontario. In fact, one of the most active DCD programs in the world. And because of the lung program, the organ yield for DCD in Ontario is probably the highest in any jurisdiction in the world. I can't say that with confidence, but certainly the highest anywhere in North America. And that's really owing to the high utilization of lungs from the DCD, and I'll show you that data shortly. So the next part of this talk is, has DCD impacted on donation after brain death? So you've already seen from our keynote speaker how brain death is becoming a vanishing entity. And if we look at cause of death for donors in Ontario, we see the same problem. much more CVAs, much less head trauma, and much more anoxia. I'll talk about the 3 errors in a second. So I'm going to show you 3 errors, and this is work that was done with from Sunny Denani and Claire Payne and Viv Rao, myself, and John McLean from Trillium, looking at the donation rate in 3 different eras. So the total donors are shown here in blue, the BDB donors in green, and the DCD donors. Okay, so they of course have gone up as we have done DCD, and I've showed you this. But what we saw was, despite more utilization of DCD donors, there's been no change in any of the donor rates and any of the transplant rates amongst, certainly kidneys have grown, livers have grown, lungs have grown, but even hearts, where currently we do not use DCD for hearts, there's been no reduction in heart transplantation despite older and sicker donors and a lot more DCD. And this is work that we've submitted for publication, hopefully it will be published shortly. One of the most important questions, and I think this came up in the last discussion, in Ontario, has DCD impacted NDD? And again, you look at the data, and you can see that at this time there was 1,700 NDD or BD donors and 286 DCD donors. The mean time in the ICU, though, was less than half that for the brain-dead donors and for the DCD donors, suggesting that the critical care doctors were not withdrawing care prematurely. And as a second important message, with NDD, one would expect asystole almost immediately. You can see that in the DCD donors, the mean time to asystole was about 25 minutes, and nobody died immediately, and 4 minutes was the earliest time, suggesting that we were not converting NDD or missing out on NDD donors to DCD. So, the last part of this talk is to focus on the transplant outcomes, and unfortunately, in Canada, we do not have great data on transplant outcomes. We're striving to get that, both locally in the provinces and Canadian Blood Services are all working to get that, but we do not have good outcomes. So I'm going to just talk about some local experience in Ontario, as I was able to get some data from my colleagues. So I'm going to start with liver, and I thank Roberto Hernandez, who was formerly from London Health Sciences Centre. This is the 2 Ontario liver programs, one in Toronto and one in London, Ontario. And we could look at the 91 DCD donors that they had. Their mean age was 36, predominantly male. And you can look at the causes of brain injury, the usual suspects here, and their BMI. And the warm ischemic time in terms of from withdrawal of life support to first declaration was about 29 minutes. And the liver program has gone, unlike kidneys or lungs, the liver program in Ontario has been very conservative and not waiting much more than 45 minutes, and even then pushing it. For kidneys, we'll wait 2 hours for death, and for the lung program, maybe up to 3 hours for the patient to pass away after withdrawal from life-sustaining therapy. So they wanted to look at warm ischemic time and hemodynamic parameters, and they had some primary outcomes of graft failure, biliary complications, which is the major problem with DCD donors for livers. It's the ischemic injury to the bile duct. And they looked at both programs, London and Toronto, and over a 7-year period, as shown here. And in Canada, all our DCD donors, of course, are controlled withdrawal, category 3 DCD donors. And this is worldwide data. This is not local data, but you can see, in fact, that in terms of outcomes from standard criteria, these are younger donors versus older donors versus DCD. The outcome for liver has not been as good, even compared to older donors of brain death recipients, brain death donors. So there is a survival disadvantage with livers, and that's why the liver program has had to become more selective. A high rate of doing intrahepatic cholangiography, basically because looking at the bile duct became a very important strategy. And in the DCD programs in Ontario, almost 50% of these patients underwent this procedure to look at the bile ducts at the time of procurement. Looking at the experience of the recipients, they were about 54 years of age, predominantly male, often with hepatocellular carcinoma and alcohol, and their sodium MELD scores were 21, and 23% of them actually had cancer. Sorry, HCV, but 23% of them had cancer, and the coldest ischemic time was 5.6 hours. Patient survival was 83% at 5 years, graft survival almost 80%, primary non-function of 4%, but you can see a high rate of biliary complications of about 18%. And if you look at the reasons for graft failure, donor age was probably the biggest reason, and that's why in Ontario the donors are usually not over 60 for liver at least. That's very different for kidney and for lungs. In terms of graft failure, the other issue that came out, here's the donor age. If the donor was less than 55, the rate of graft failure was only 7% versus 33% for those donors over the age of 55. Nothing else was really predictive of graft failure. In terms of biliary complications, low blood pressure at the time of the withdrawal, after withdrawal, seemed to be indicative of a higher risk of bile duct ischemia, shown here. And this is the period of time for MAPS under 50. If it was more than 25 minutes, there was a much higher rate of biliary complications. So graft failure in 4% of patients, biliary complications in 24% of patients. And donor age was really the limiting factor here, and that's why they are limited up to age 60 in Ontario for the most part. And the blood pressure after withdrawal was a predictor of biliary complications. In terms of the lung program, and I thank Dr. Seipel from Toronto General for sharing this. Toronto, for those who don't know, was the first world's successful lung transplant program in both single and double lungs. And what's shown here is the volume of transplants, and in red are the DCD donors. And Toronto, as I said, has made a very, very high use of these DCD donors. And one of the things that has made this successful is the very innovative extracorporeal ventilation and perfusion of lungs by Dr. Kashashvi and his team. And what you can see, in fact, is that the vast majority of DCD donors, in fact, received this strategy. This not only could test the lung, but can repair the lung ex vivo and reimplant it. And this has been a very, very successful endeavor, but highly used for the DCD lungs. Remember, they're waiting up to 3 hours sometimes for these donors to pass away after withdrawal of life-sustaining therapy. This is old data. I didn't have any recent data, but they had 42 out of 220 donors at that time, or about 19%, and they represented about 16% of all the lung transplants, with a utilization rate of 38% of all DCD donors. Lungs were used 38% of the time. That's, I think, is the highest in the world in terms of utilization of lungs from DCD. And this is a little bit schematic of their brain-dead donors, 432 and their DCD donors. And the outcomes, one can see, in fact, were fairly equal in Toronto across the board of these donors. Of course, there's a major difference in the numbers, but across all outcomes in terms of primary graft dysfunction, early on, at day 3, the need for ECMO, ICU stays, everything was quite similar. And they actually have very good results across the board. And this is their survival rate, ultimately up to over 1,800 days between the brain-dead donor recipients and the DCD donors, and really no significant difference. So I'll move on to the most important organ in the body, which is the kidneys, and I say that because I'm a nephrologist. And by the end of September, there was over 850 transplants from DCD donors in the province of Ontario. Most of our kidneys are placed on pulsatile perfusion pumps. And this past year, actually 2015, our kidney working group made a decision to extend the age of DCD donors from 65, which was our upper threshold. Remember, it was 60 for lungs, 65 for kidneys, and now it's 70 for DCD. And as we've heard in Spain, it's over 80 for NDD, but we're 80 for NDD in Ontario. And our definition of an extended criteria kidney donor is a donor over the age of 60, or a donor between the age of 50 to 59 with 2 of the 3 criteria, either a history of hypertension, a bleed as opposed to trauma, or a terminal creatinine of greater than 132 micromole per liter. Now, you may not be able to read this, but in the United States they've gone to KDPI, and basically they look at the donor score. Instead of ECD, they give you a score. So what's shown here is a score of 2 donors. The higher the score, the worse the outcome. So these donors have scores of 85%, and 75%, which means that this donor is better than only 15% of all deceased donors. This donor is better than 25%, and the only difference here is the DCD. So in the United States, they have recognized that a DCD kidney donor probably has some inferior outcome to a non-DCD, and this is looking after thousands of transplants. And that's important because currently we do not consent recipients for DCD kidneys in Ontario, at least I don't. Looking at our own data, well, we reported on the 3-year outcome across Ontario early on in 2007 and 2009, and at that time, DCD and NDD outcomes were equal for kidneys. The DCD, ECD, the older DCDs had worse function, but they were very highly selected DCD. We were very conservative early on. In the more recent era, as I said, we are getting DCD donors up to age 70. And I showed you this earlier on, much more anoxic brain injury than trauma. And this is both true for brain dead and DCD donors. So early on, our 1-year survival was 96%, graft survival death center was 97%, and a lot of need for a lot of delayed graft function. Here's the use of delayed graft function, defined as a need for dialysis, so about 70%. And what we saw was that the renal function was inferior for the DCD extended criteria kidneys at 12 months than the standard criteria. So what about in the modern era? And I have a few more slides before I end. So this is my own hospital program, looking at the last few years where we've been using much older DCD donors. So this is just living donors and deceased donors during this 4-year period of time at my hospital. And you could see that living donors were a little bit younger. These are the recipients, by the way. They had a little bit better renal function than deceased donors, a little bit better hemoglobin, and similar albumin to creatinine ratios. When we look at just the deceased donors, and there's 4 categories here. The NDD, the brain dead standard criteria donor, the NDD older donors, or ECD, and the 2 DCD categories, standard criteria and ECD. The numbers are getting a little bit small here, but what you can see, of course, is that the recipients, we give ECD kidneys to older recipients. So, of course, those recipients getting ECD, DCD, or brain dead are older, but as we got into the DCD categories, whether they were actually getting standard criteria kidneys or older, they actually had worse creatinines even than the ECD brain dead donors. So this is a little bit of a concern. A little bit lower hemoglobins, not much difference in ACR. This was not significantly different. So the DCD donors in our current criteria, even in the younger ones, seem to be having a little bit worse renal function than the brain dead donors at our hospital, at least. Graft survival, also a little bit worse for the ECD. This is for the ECD donors compared to the NDD donors. And when we look at the 2 SCD categories, you can see that they actually are lower than the brain dead categories in terms of graft survival. This is at 3 years. Death sensor graft survival, because patients do die, those numbers seem to diminish. They're no longer statistically significant, although there is a little bit of a trend. So, in summary, DCD is the fastest growing source of deceased organ donors in Canada. We now exceed the United States at around 21%. I don't think there's any impact that DCD impacts the missing of brain dead donors, at least not from the data that we have. We actually have the largest percent DCD donors in all of North America at over 30% in Ontario. The lung outcomes are comparable to brain death. Liver outcomes are somewhat less favorable, but I think you have to select the patients well and watch the ischemic time. Kidney outcomes are probably inferior, and that's something that we may have to start telling our patients. I don't think we're actually telling that to our patients now. We know there's a higher rate of delayed graft function, but it looks like even graft survival and renal function may be starting to play a role, particularly as we get more expanded DCD donors. Thank you very much.
Our next speaker is Dr. Bernard Cantin. Dr. Cantin is a professor at the University of Laval. He's the chief of cardiology at the Quebec Heart Institute. He has been heavily involved in the development of the Canadian Cardiovascular Society guidelines for heart transplantation and is currently the chair of the Thoracic Organs Committee at Quebec Transplant. He will be speaking to us about heart transplantation utilization decisions, which is a topic that is of great interest to us as critical care professionals, because hearts are utilized only in about 35% of NDD organ donors at present in Canada, and so we'd like to hear more about some of the reasons for that and perhaps ways to increase that number. Dr. Cantin.
Thank you very much. It's a pleasure to come tell our side of the story. I understand it can be very frustrating for most of you guys at night when we say no, because it always happens at night, of course. Okay, so I'll try to walk you through some of our decision making and helping you understand why sometimes we say no to your offers. Of course, I have no real disclosures here. I'm a heart transplant cardiologist. I'm willing to do anything to increase donation. Doesn't mean I'll accept the hearts you're offering, but I'm willing to go to increase it. And I work for Quebec Transplant. Okay, so I'll paint you a very, very rough picture of what's happening to a heart transplant patient. So what do you expect in a heart transplant patient? What we're looking at here is the overall experience with heart transplantation, about 100,000 adult patients. What you can see is that we have a very sharp decrease in survival at the time of the operation, and then the patients will live roughly 10 years overall. In hearts, very often we give what we call a conditional half-life survival for our patients, meaning that since there's a lot of mortality in the first year, if you've survived through the first year, you can expect a life expectancy, you can expect about 13 years. So sometimes that's a number you will see in the ISHLT slides, conditional survival. If you take a look at the beginning of that curve, what you see is that there is a very sharp, that's the first year that I've just blown up, and what you can see is that there's a very sharp death happening in the first month, and then it's tapering off with, it will then keep on tapering for the remainder of the lives of these patients. But it's really the initial part, the first 30 days, is very critical for us. We have different types of patients. Most of our patients have dilated cardiomyopathy or coronary disease, and that's their life expectancy. And these two lines here are for patients with valvular or congenital heart disease. Very often, these patients have been operated more often, and the extra sternotomy that we're doing for the transplant and surgery, sometimes they don't fare as well. So their survival is not as good. Okay, I'll just quickly go through the listing criteria. Of course, it's much more complicated than that, but we work with different status. Status 4 being the emergent patient, most often on ECMO, intubated with sometimes in a balloon pump, but nowadays we mostly go ECMO intubated, or VAD complications. We have the status 3.5 patient, who is also a very urgent patient in whom most of the time VAD is not an option. In that category, sometimes we put some sensitized patients as well. We got the status 3 patients that are mostly VAD patients. When we redid the criteria, we favored VADs for our patients and gave them a special status, because these machines are good, but they're not that great long term. And then we got the status 2 patients, who's your hospitalized patient on inotropes, and then the one that's at home, status 1. So basically that's about it, of course. And again, showing their survival, but that's I've already shown you that. Status 4 patients, very often they're frustrating for the transplant coordinators, because you have a heart, you're allocating it in your province, and then here pops a status 4 patient. Many years ago, we looked at, when we redid the guidelines, what we had done is we looked at the survival of the patients that were listed as status 4 patients over 2 years. There were 43 of them, and their 30-day survival was 65%, which is well below what we're expecting for our heart transplant patients. That's when we redid the criteria to try to steer away from these patients and favor VAD implantation in them. And the status 4 patient have a 1-year survival of 56%. So it wasn't a very successful group, so that's why we changed the criteria. Nowadays, status 4 patients are doing much better, but there's much less of them, which is a good thing. So basically, when you're doing heart transplantation, what do you expect? You expect significant mortality. You know, when we're talking to our patients, we're telling them it's going to be a 10 to 15% mortality in the first year, most of it being front-loaded to the first month. Again, especially in the higher status patients, we're expecting a lot of mortality. And we're expecting a 15-year survival if you make it through the first year. So now let's look at the offers we're getting and how we're analyzing them at night. It's always in the middle of the night, and there's always someone who's telling us that heart is good, that heart will recover, and we're always a bit, skeptical. And we should be. I mean, we're dealing with death. So the guy who tells us that the heart will recover is probably right, but here time is really not on our side. Some of the issues we have our donor stability, families, planes, trains, and automobiles. It may not be obvious to you, but I'll show you that there's an impact. And then there's the people involved, the cardiologists and the surgeons being the worst, of course. When you talk about donation, it's usually a kidney business, and everybody's worried about delayed graft function. It has to go back on dialysis, and that seems to be very, very bad for the patient. I really don't understand that because, delayed graft function in heart is a real problem. We do have the ECMOs. However, what you can see here is that these are patients that have been transplanted, and some of them we had to resort to putting them on the ECMO post-transplant, and that's 30-day mortality. That 30-day mortality is around 50%. So our main worry is, will that heart start? I mean, if the heart doesn't start and we put the patient on ECMO, he's at significant risk. When you look at the causes of death, the early causes of death, that's the first month here for our patients. The most significant cause of death is graft failure. So that's what we're always worried about. And then you got the multiple organ failure and a little bit of the infection. Infection, of course, as we go out more than a month, becomes a more important factor. But these are the important factors to us, the graft failure and the multiple organ failure that usually comes with it. All right, one of the things we have to consider is distance. Distance for us is a problem because distance is time. These are not heart, these are not livers, these are not kidneys. Time is a more important issue. What you can see here from 5 years of transplant in the world, what you can see is that around 3 to 4 hours of ischemic time is the ideal, and the further out you go from that ideal time, the higher the risk that the patient will die within the first year, bearing in mind, as I told you, that most of that mortality is really close to the operation. So we have to reduce these ischemic times. One of the issues we don't like is traffic. It seems odd, but when you get an OR in Toronto and you're going to come out with the heart at 8 in the morning, it is not a good idea. In Quebec, we're lucky. The police organizations are pitching in for the organs to be transported from the airports and the teams to and from the airports. So we get a little bit of reduction of these ischemic times because of these dedicated transports. But in most places, Ontario, and the one we don't like the most, not that we don't like the people from Halifax, but it's Halifax. The airport is 45 minutes away from the hospital, if not 50, and you're taking a cab. And so, of course, he's respecting the speed limit, the traffic lights and everything, and the counter is ticking. So it's a very important issue for us, the ischemic time. All right, coronary disease. That's one we don't like. We have people do the angiograms very often, and being out of Ontario, sometimes we're frustrated with Ontario in that they do not transfer the donors from one hospital to another, so you can't always get the angiograms, and sometimes you get a CT scan instead, but a CT scan it's really not an angiogram. Why are we worried about coronary disease? It's rather simple, because all of our patients will get coronary disease, most of them. What you can see here is the normal what you can see is the transplant patients as they, I'm sorry, I do medicine in French, sometimes I get hooked up on words. So what you see at the further out you are, the more coronary disease there is in these patients. So we don't like to start out with the coronary disease. And it's not just a question of looking at the coronary disease and seeing it's there that we don't like it. It's because these patients with coronary disease do not fare as well as the others. Their survival is not as good as the patients without coronary disease. So of course it's a significant issue for us, and we try to steer away from coronary disease as much as we can. What you will find if a patient has an emergent status 4, status 3.5, and there's a limited amount of coronary disease, very often the transplant organizations will go for the heart. But if it's for a patient that's at home on status 1, we will usually decline the heart if there's any kind of coronary disease in it. The other issue is the donor age. I'm always impressed when I see kidney people going up to 80 years for their donors. Of course, we don't have that luxury, but we're being pushed to it anyway. So here is what's been happening around the world as far as donor age is concerned. As you can see, in Europe, the mean age for the donors has been increasing steadily over the years. We are North America. It hasn't changed really that much because in North America there's the US, and if you're a heart transplant physician, then you sponsor the NRA. It makes sure you have a good pool of young donors available. And when you go to these heart transplant meetings, and we're very happy with our 45-year-old donors, the Americans saying, 45? Are you crazy? We don't use that. Well, that's what we have. So our curve is more like that of Europe than the one from the United States. So did it have an impact? Yes, it does. Again, above 30, 40 years old, the recipients do not fare as well with older hearts. Hence, we're putting this in the equation at night. As you can see, if you look at the different, the incidence of early graft failure, the heart delayed graft failure, that's not as good as the kidneys. So the younger donors, there's a certain amount, there's like 3% of graft failure, but you go up close to 10% when your donor is more than 60 years of age. So then you factor in the age, the ischemic time, and the urgency of the patient. So these are all very important. You cannot look at a kidney that's 65 as you would look at a heart in a 65-year-old donor. It's not the same thing at all. And that's just another way of seeing the same data, in that the survival of patients who've had older donors is definitely not as good as that of those with younger donors. Sex, it's an important thing for us. Sometimes you get a heart, but it's from a female donor or a male donor. It is an issue for us. There is, again, more early graft failure in females than there is in male. And then there's the match for us. What you can see here is that the female donor in a male recipient, so that's a very, very, very big number, 17,000 patients. So there's a lot of patients there. But you can see that they do not fare as well. They have a worse survival than the male in male, female in female, or male in female. So that's also an issue for us. Recently, you have been involved with mechanical support in most of your patients. What's currently used mostly here in Canada, the Heartware rotary pump, mostly the HeartMate axial flow pump, and of course there's the ECMO that's always been there, and that's very useful in case of an emergency. Over the years, again, as I said, we changed the listing criteria to favor VAD as a stabilizing mean before the heart transplant. And you see that about 50% of patients nowadays are on VADs before they get their transplant. That's worldwide experience here. And this is very important because, when you look at the survival, that's a problem with the ISHLT slides. There's always a lot of colors and lots of data, but I'll walk you through the important ones. The one in purple, the survival of patients that are not on VAD or inotropes. In yellow, the ones on VADs and inotropes. And you can see here that the patients have been bridged through VAD, fare rather well, but still not as good as those patients who didn't require these therapies. And these are the ones we don't like. These are our status 4 patients. These are the patients on ECMO. You can see a very, very important death rate early on. But if you do the conditional half-life, those that have lived past the first year, even those patients on ECMO will do as well as all the others. And as you can see, they're all one on top of the other, basically, because it's the early operative period that's the deal breaker for the survival. Okay, so VAD, again, very useful, but we're nowhere near the ideal VAD that we'll put into everyone. They have issues. This week, all the Heartwares were recalled, all of them. So it's kind of, we're not there yet. Okay, the other thing that most of you people are involved with is helping us optimize the heart using the Solumedrol, the T4 hormones. I'll just quickly show you the data from what when we started doing this in Quebec. We looked at our data from 2007 and through about half of 2012. Then we stopped because the funding was more difficult to get at Quebec Transplant to keep looking at these data. But using the standard protocol that most of us are using, we had 75 donors that went through the protocol, and of these, we got an extra 27 transplants over the year. What's more important for us is the recipient, of course. The EFs, you were talking to me about the EFs. I would say that the EFs in these patients have not been a problem at all, and we've had 4 deaths in these 27 patients. So just quickly, what we did, of course, these are echoes we're doing before and after the treatment, and when we looked at the data, we basically said if it's more than 10%, we consider it improved. If it was between a reduction of 10 or an improvement of 10%, we said that protocol was neutral, and if the EF decreased to more than 10%, we said it was a failure. And we had 27 patients, so basically more than a third that had an improved EF. It improved on average by 17%. And what's important is that this donor had a 25% EF to start with, and he finished at 65. Sometimes people think that if you start at 25, it will not go any higher than 30, 35. It's not the case. It can go much better. So overall, the final EF was 52%, and out of these people, we got 21 transplants. You understand that cardiologists are very reluctant to transplant below 50% because we're taking the heart out, putting it on ice, and then trying to restart it again. And you should see it when they restart. It's not starting that easily. It's not like on TV. On TV, you get the phone call, he's got the heart transplant, and then you go to generic, everything went fine, but this is not our reality. So below 50, it's very rare that they will be used. We've had 40 patients that were considered neutral, no improvement, And we got 8 transplants out of those, because mostly people going from 45 to 50 to 57. So we did get 8 hearts out of those. Those that were, they basically got all the same management and the same management time. Those that were improved maybe had a longer management time, probably because of the allocation issues. They needed more time then to just reallocate the heart. And we never lost any organs of the donors while doing that protocol. So that was very interesting. So the improved hearts, about 75% of them went to transplant, and the neutrals about 20%. So that was very, very useful, because over those years, these are the number of hearts that were transplanted in the province over those years, and we went from 4% of the used hearts were optimized, then went to 14, 18, and basically nowadays we're still running about 20%, 15-20% of the hearts we are harvesting are coming from the optimization protocols. Their survival has been good. It's been 85% at 6 months. I'll just remind you that what we're hoping for them is around 85% at a year. It's very decent. So so we're very happy with those. It's been good for patients on the waiting list. Status 4 patients could get transplanted within 9 days with these hearts, and that's what's very important, is that in the transplants we did, 23 of the transplant went to patients with a high status, those at higher mortality risks, and we're getting good numbers with that. So the cardiac optimization process has been an important source of hearts, and you are the ones that are most involved in it. And I think they can be used safely in patients with advanced listing status. So I'll stop here, and we'll discuss this later. Thank you.
Our next speaker is Dr. Dominguez Gill, who's already given us 2 great talks this morning. She's a recognized leader in the field of donation and transplantation in Europe. She's a past chair of the European Donation and Transplant Coordination Organization, a board member for the Spanish Transplantation Society, and the chair of the Transplantation Society Ethics Committee. She will be speaking to us about organ utilization in Spain. Thank you, Dr. Dominguez Gill.
Well, thank you. Thanks to you for resisting 3 talks on my side. So thanks for that. Okay, we've been talking this morning about how our system in Spain was able to reach very good levels of diseased organ donation. When we take a look to I don't get along with this mouse, I'm sorry. When we take a look to the utilization of these donors, we have rather disappointing figures. So we take a look to the organ utilization rates. This means the percentage of actual organ donors, at least 1 organ recovered, from whom at least 1 organ was transplanted. And the number of organs transplanted per donor in the country, you can see a utilization rate of 88% and 2.8 organs transplanted per donor. So the question is, are we making the most of our diseased organ donors? Are we just, losing organs inappropriately some way? If we're going to explain these 2 figures, I think it is important that we place ourselves in the current reality which is shared with other countries. This is the situation of the waiting list in the US, how it has evolved over the years, and although the number of donors and transplants has increased as well over the same period of time, you can see the huge gap between supply and demand of organs for transplantation. And the situation is not different in Spain. This is the number of patients active on the waiting list over the year, and this is the number of solid organ transplants that we are performing. And we take a look to the gap between supply and demand, we have to be really very critical. For example, when we take a look to the first treatment that patients, incident cases of end-stage renal disease, receive in our country, only 5% of them receive a preemptive kidney transplant when they are lucky enough to have a willing live organ donor. An excellent marker of self-sufficiency in transplantation would be being able to provide transplantation services before dialysis therapy, and we are unable to do that. This is exceptional in our country, as it is in most of our countries. And things are not getting better. We were discussing this morning the evolution in the incidence of brain death in the country, and our potential DBD donors are changing their profile in a substantial manner. So for you to have an idea, we have evolved in approximately 10 years from a mean age of 50 years among persons who die in a brain death condition to 60 years. And now, of course, the majority of them die in the context of a cerebrovascular accident, particularly an intracranial hemorrhage. So that is the profile of our potential DBD donors. So if this is happening in our country, mortality relevant to organ donation decrease, there are improvements in the care of neurocritical patients, we have less potential DBD donors, and with this changing profile, if we want to ensure organ availability, we simply need to change our eligibility criteria for organ donation. And of course, that has a price. So we have developed certain strategies to increase organ availability in our country, but they are going to be impacting the value of these two indicators, utilization rate and organs transplanted per donor. Let's talk about the aged and very aged organ donor. We saw this slide this morning. This is the evolution of the age of our deceased organ donors in Spain. And as I said this morning, if you take a look to the year 2015, 50% of our donors are over the age of 60, but 10% of them are over the age of 80. So we have adapted somehow in our actual donation rates to the profile of our potential DBD donors. And if you take a look to the causes of death, this has occurred as well. The majority of our donors have died as a result of a cerebrovascular accident, particularly an intracranial hemorrhage. Are other countries considering all donors as potential donors for transplantation purposes? These are data from the European Union. You can see actual donation rates split in red for donors over the age of 60 and in blue below the age of 60. And there are many countries in Europe which are actively considering the use of organs from all donors, but not as much as, for example, Italy, France, or Spain, the southern Mediterranean countries. What happens in the US? Well, this is a very interesting paper which was published some years ago in which the authors compared actual deceased donation rates per different age groups. It was astonishing to see when they focused on donors over the age of 75, how in the US they have only increased their activity very slightly, and how in Spain the use of organs or the consideration of organ donation from persons over the age of 75 had exponentially increased, to the extent that the authors were concluding that the only difference between the US system and the Spanish system was that we were actually considering organs from very aged donors, which they were not doing. What is the impact of donor age on these two indicators? Well, you have it here in the slide. This is the utilization rate for donors below the age of below the age of 60. So it's close to 95%. And of course, the value of the indicators decreases as the donor age increases. But if you take a look to the extreme age of donors over the age of 80 years, utilization rates is of 74%. So there will be many instances in which organs from these donors will be recovered and not transplanted, but in 7 out of 10 times, at least one organ will be transplanted successfully, as you will see afterwards. And if you take a look to the organs transplanted per donor, we have the same situation. For younger donors, the mean organs transplanted per donor is quite high, 3.6, but it decreases with donor age. But once again, if we take a look to the oldest group, the number of organs transplanted per donor is 1.7. So we make a use of organs which otherwise would be lost for transplantation purposes. What is the price to pay? We have an enormous number of organs that are discarded for transplantation, and we have decided to assume that. So here you have the number of kidneys that are recovered every year in red over the age of 60, in blue below 60, and here is the number of livers. And you here see the discard rates, which can be as high as 25%. But we assume that. We risk and we assume that lost. What is happening in other countries? For example, in the US, where you can see that the use of organs from these donors is quite rare. For you to have an idea, in 2015, only 7% of their donors were over the age of 65 years. The number of organs transplanted per donor is of about 3, so it's not that different from ours. And when we take a look to the discard rate of kidneys in this country, they are not that different from the situation in Spain, surprisingly. This is a paper which was just accepted for publication in Transplantation, where you can see how discard rates of kidneys recovered in the US have gone up to almost 20%. And the reason for that, according to a very refined analysis that the authors did, was definitely related to expanding slightly the donor pool. So if you want to consider organ donation from all donors, you have to assume the costs and the efforts of going to make a recovery and not using organs in some occasions. But of course, we can see the story in an optimistic way or in a pessimistic way. Organ discard is something that we don't like, but what is the benefit that we get from this strategy? So here you have the percentage of solid organ transplants that have been performed with organs within this age group of donors. So for example, in 2015, 40% of our solid organ transplants were performed with organs from donors over the age of 60, and you can see the contribution of very old donors to 5% of our solid organ transplant procedures. So the question would be, what would we do without them? I mean, we wouldn't be able to cope with the transplantation needs of our patients. Here you see the solid organ transplants per organ type, when you can see the contribution of these age donors during a 5-year period. So 40% of our kidneys are obtained from these aged donor groups, and 50% of our livers. But importantly, more and more lung donation is being considered from these extreme donor age groups. How do we allocate these organs? But particularly for kidney, we use an all-for-all allocation strategy, which allows us to give a nephron mass which is sufficient to cover the survival expectancies of all recipients who otherwise wouldn't have access to transplantation. So here you have the correlation between the recipient age and between donor age. And patients within this age group are given the chance of accessing transplantation, which otherwise would be unlikely to have. What are the results? The results of organs from aged donors are never going to be the same as those obtained with young donors. But we don't believe that's the comparison that we have to make. Of course, they are always going to be worse. The question is whether they provide us advantages with staying on the waiting list. And this is a very interesting study published by a Spanish group very recently, in which they compare the mortality after transplantation from organs, from kidneys from donors obtained over the age of 75 years, compared with the matched counterparts which remained on the waiting list. And the probability of death on those on the waiting list was 2 times higher than that of recipients who were transplanted with these aged kidneys. So it does provide survival advantages compared to not being transplanted or taking a huge amount of time in being transplanted. This doesn't mean that we are comfortable with our discard rates, and somehow we feel responsible as a country which is very active in the consideration of organs from aged donors to see how we can make a better use of these organs. These are the reasons for discarding kidneys from DBD donors in Spain during the year 2015, where you can see several factors that could be amenable to change. For example, biopsy. Is biopsy alone sufficient to consider an organ not transplantable? Well, this is put under question in many papers, and this is something we have to look at. Surgical accidents are other problems, but for example, in other occasions is a donor unsuitability or thought to be donor unsuitability identified in the surgical, in the operating room. How are we working on this? Well, in the very first place, a couple of years ago, we prepared a consensus document about the way of evaluating kidneys from expanded criteria donors, given a relative value to the biopsy and to the value of parameters that are obtained from pulsatile perfusion devices. But of course, our work is going to be focusing in the years ahead on whether the decisions that our professionals are making on whether to use organs or not are based on subjective considerations of those organs or on objective factors that are determinant of post-transplant outcomes. And this is work ahead for us. Importantly, what happens with what we call the non-standard risk donor? In our quality assurance program, and this is something that affects also to organs that have been recovered, I told you this morning that on many occasions potential donors do not transition to be actual donors because of medical unsuitability. When we performed external audits to the centers, we found out that at least in 10% of the occasions, these medical contraindications were inappropriate, or at least they were debatable. The physician in charge of that patient did not refer the patient because he thought the donor was not a suitable organ donor, or even the donor coordinator considered inappropriately that there was a medical contraindication to organ donation. So how did we handle this? In the very first place, we have been providing guidance in the form of how to consider or what is the risk-benefit approach when having a donor with a past or present history of a malignancy, with a specific infectious diseases, guidance that has been inspiring international work as this Council of Europe Guide on Quality and Safety of Organs for Transplantation. But besides, we have a physician on call at ONT, 24 hours available for a second opinion in any complex case that donor coordinators face. But of course, that is not enough. We need to provide good evidence in order to make risk-benefit assessments. And I'm talking about, for example, I find a malignancy in a kidney during the recovery process. What do I do with all the organs? What do I do with the contralateral kidney? What do I do with that kidney itself? This is going to be a factor that is going to be affecting the consideration of organ donation and decisions made about discarding kidneys or other organs or not. But of course, we know that any recommendations that we give in this field are very limited in the underlying evidence behind. So we have moved to what we call the non-standard risk donor project, in which we are systematically and prospective following up all recipients transplanted from donors with specific characteristics which raised doubts about the safety and the quality of these organs, donors with malignancies, infections, poisoning, or other diseases. So prospectively, we collect information about the situation of these recipients, and professionals in charge of the data collection receive an alarm reminding them that that recipient has been transplanted with an organ from a donor with whatever circumstance, and provide information about the outcome of these recipients. And we do consider this is a project that is going to help us deal with some of the inappropriate losses of organs for transplantation. We provide annually a report on non-standard risk donors. So 5% of our actual organ donors, we know they have a non-standard risk donor criteria. And so far, there has been only one case reported of a disease transmission, which was expected. It was an HCV positive heart used into an HCV negative recipient who was in a very poor condition. The recipient acquired the HCV infection and was successfully treated with a novel anti-HCV therapy. So it is providing this program a huge amount of information for us to substantiate future recommendations about the use of these organs. The other element which is impacting utilization of organs in Spain is the DCD program, as it is happening here. We have seen this morning the evolution of DCD rates in Spain, both from uncontrolled and controlled DCD, and I have shown you before the relatively low effectiveness of the uncontrolled DCD process. When we take a look to the number of organs transplanted per donor in the DCD setting in red or in the DBD setting in green, you can see the huge gap between these two lines. Moreover, in Spain, so far, only 36% of the DCD procedures are multi-organ donor procedures. Most of these donors are only kidney donors. And we know this difference somehow is unavoidable because of the nature of the DCD process, but of course we can improve. This is something that does not only worry Spain, it worries other countries. These are data from the of the UNOS report, where you can see the number of organs transplanted per donor in DCD is about 2, compared with more than 3 in the DBD setting. Or for example, in the UK only reported organs recovered, not transplanted per DBD donor and DCD donor, with a huge difference between the two. Although they have managed to make 53% of the DCD procedures multi-organ procedures. But this is a challenge for all countries which are embarking in controlled or uncontrolled DCD programs, as you in Canada. The impact on transplantation is incredible, but how can we do better? So what we are trying to focus in is on how to move to multi-organ recoveries in controlled DCD. In Spain, organ recovery is organized locally by local teams for kidneys, but livers, lungs, and other organs and hearts are recovered by the transplantation team. So we have a very specific type of organ recovery which is challenged by the controlled DCD setting. So what we want to do is that even hospitals with a very limited potential of controlled DCD and limited capacity are supported by bigger, larger hospitals with more resources and more capacity. We want them to develop protocols with reference liver and lung transplant centers, moving from the only kidney recovery to the multi-organ recovery. And now we are moving to a way of working which an early communication of potential controlled DCD donor cases allows ONT to organize multi-organ recovery when the reference centers do not accept the specific organs for whatever reason. Also, as you will see immediately after, we are seeing some advantages of NRP, of normothermic regional perfusion in controlled DCD setting. And if this is confirmed, we will be organizing regional teams with ECMO devices covering specific regions, and there is already a pilot which is being running in the community of Madrid. Increase the utilization of organs without compromising post-transplant outcomes is going to allow us to understand very well the factors that determine these post-transplant outcomes. And as I said before, we are intrigued about in situ and recovery techniques. What types of techniques are we using in Spain? This is for controlled DCD, where you can see how about 24% of our DCD procedures are now performed with normothermic or hypothermic regional perfusion. Rapid recovery, which is the one that you perform in Canada, is very frequent, is the most frequent, but as you can see in the slide, progressively more teams are moving to NRP. What is the impact of that strategy in organ utilization or in organ consideration? Well, especially in livers is very high, and possibly because the transplant teams feel much more comfortable with NRP than with a rapid recovery. So for example, while liver donation was considered only 44% of occasions with a rapid recovery technique, the liver was considered in 71% of the occasions when the recovery was being performed with normothermic regional perfusion. So that might increase the utilization of livers from DCD donors. And what is the impact of post-transplant outcome of this technology? These are data from DCD liver transplants in Spain, 107 liver transplants from DCD donors, both controlled and uncontrolled. And when we take a look to factors determining graft loss in the short term, we could see that of all the factors that we studied, donor and recipient age did not remain in the model, curiously, in the multivariate model. The Maastricht category did not remain in the model, and the critical factor determining post-transplant outcome was the type of in situ preservation recovery technique used. So when we used rapid recovery, the chances of graft loss was 2.5 times higher in the multivariate analysis than when we used NRP. And this would be graft survival with rapid recovery and with NRP in a multivariate model. This is adjusted by donor, recipient age, and Maastricht category. So we really think that NRP in controlled DCD is going to help us to increase organ utilization and improve post-transplant outcomes, particularly in the liver setting. So in conclusion, the two components of the Spanish strategy to increase the donor pool and the availability of organs are expanded criteria donors and DCD donors. And the utilization rate and the number of organs transplanted per donor are definitely reduced compared with the standard criteria donor in these two settings. However, the contribution of these two types of donors to the transplantation activity is impressive and is becoming essential if we want to cover the transplantation needs of our patients. But further work of the Spanish system is targeted to the identification of factors that can help to increase the donation and utilization of different organ types without compromising post-transplant outcomes. Thank you for your attention.
Hi there, Sam Shemy from Montreal. Thanks for that very interesting presentation. One of the reasons that we arranged this session was to manage the inevitable consequence of increasing intensive care engagement and commitment to organ donation. And inevitably what happens is what you guys deal with, which is why didn't you accept this donor and why didn't you accept this organ? And there needs to be, we did a study, Karen Hornby in fact did a study a number of years ago looking at variation in heart and lung utilization across the country. And there is what I think from an intensive care perspective we accept is if there are clear criteria for acceptance and refusal, that's fine. But the question is, what is the process to do that? And is there a formal way that transplant programs are accountable? Heart and lung utilization vary across the country, and they vary according to transplant program maturity, transplant program comfort, and experience. In addition, often there's premature decisions made in donors based on early evaluations of organ function, and Bernard, as you showed, serial evaluations of heart function can change that. In addition, we've all had experiences where the donor's characteristics, the primary disease, may be misunderstood by our transplant colleagues. And it's insufficient, I think, just to hear from the donor coordinator that they said no to the donor or they said no to the organ. And I'd like to understand can we develop a better process of accountability so if I hear no from my donor coordinator in my center, I don't have to get on the phone and call Toronto and say, hey, would you guys consider this donor or this heart? That there is a process of so-called shopping the donor or shopping the organ to other centers so that the ICU community can be reassured that due process is given to every donor and every organ.
I can speak to that. Part of my work at Quebec Transplant is being on call at night for the coordinators, and they will never stop the allocation of a heart if the criteria are not very, very, very clear, and they will always refer to us and ask us where to go. And very often they ask us, should we also offer it to UNOS? I would say that most of the time when the organ is decent, we do take them, and especially if it's an O, a 70 kilos O heart will always find a place for the heart. It's very rare that we will not be able to do so. As far as the different programs are concerned, it's a bit different. We have a program in the province that will not use the optimized hearts. They're not comfortable with that, but the other two programs do use them easily, so there's kind of a fail-safe there. In our program in Quebec City, all of the declined donors are reviewed 3 or 4 times a year. We go through this with Quebec Transplant. They send us a coordinator, and when the heart was used in another program, we look at it even more closely. So it's more of an individual way to do it, but there are some processes that are there to make sure that the work you're doing is not for nothing, and we do try very hard to place them. But then again, I want to stress again that we're dealing with a 10 to 15% mortality, and it's a very hard decision, because if you go to have a heart valve surgery, they will say that the surgery is high risk if you have a 5% mortality rate. So hence, we're always a bit more tentative because of that. The lungs in Quebec for a while went very well, and the program in Quebec at some point started using a bit less of them, but Toronto always comes to get them. So they're always used. I think that's the most important thing. And when we look at it on our side in Quebec Transplant, wherever they're used, we're happy.
Maybe I can just add to that. I mean, I wish there was a simple protocol and understanding. Transplant physicians and surgeons sometimes don't always think about the next person in need of the list because they're not dealing with them, although those patients do pay a price. We know that even within the same institution, there's differences of opinion amongst accepting all kinds of risk, whether it's the older donor, the DCD donor, the high social behavior risk donor. There's all kinds of risks and people are different, and it is difficult. Similar to Transplant Quebec, we have a system of people on call all the time. We don't shut down cases unless someone makes that decision to. Organs can be offered to multiple programs. It's always nice to have multiple programs, but it's not always straightforward. And it's sometimes easier for someone to say no than to have to deal with the consequences of a difficult potential donor in a bad outcome. And that's just the way it is. And I wish we could make it simpler and streamlined, but human nature, and I get the same calls from Andrew and Sonny in his last, is why didn't anybody use these organs? And it's hard for me to justify why a colleague, a heart transplant colleague, decided not to choose this particular recipient. It does merit discussion, though. I don't know how we formalize it better, but as long as there's physicians and surgeons who are the ones looking after the recipients, there are going to be organs that are probably not going to be used that should have been.
So we understand the variability in decision making. I guess I would push you a little bit to say that there needs to be an enhancement in the transparency and accountability around decisions about donors and organs that is fed back to the ICU caring teams to avoid this scenario, which is every time I ask, they say no, so I'm not going to care anymore, and I'm not going to push anymore. And it's not our role to push. It's our role to communicate, and it's you guys' role to communicate back as to why.
I would agree with that, actually.
So I would urge our transplant community in general to develop something that's a little bit more accountable than is apparent to us now. Beatrice, I'd love to hear.
Just to add something to what has been said, it is also important to understand that acceptance criteria might also vary depending on the situation of patients on the waiting list. So of course, if you have a patient in a very poor condition, you are more prone to take more risks than if you have patients in a very good condition. So there are many factors that are going to be determining whether a transplant team is going to accept an organ for that recipient or not. And the process is very, very complex. As you do here, we do try very hard to allocate all these organs. Particularly for expanded criteria donor kidneys, we have what we call the rescue allocation policy. So when we see that the organ is not going to be accepted, we have identified teams which are very active in the use of organs from aged or very aged donors with very good experience, with a lot of practice in the use of these organs, having very good outcomes, and they get these organs. So there are also systems to facilitate that at least some centers acquire good experience to get the most of these organs. That's an issue that is being used in a practice which is common in Eurotransplant as well. and it's working very, very well, especially for kidneys, for the very old kidneys.
Actually tags on quite well to Dr. Shemi's, is that as a I work at Trillium Gift of Life, and the question always is the urge or the urgency to get the donor to the OR costing us hearts? This question is for you, Dr. Cantin. How long, so the example would be a young donor, traumatic brain injury, declared brain dead, an echo is done. The echo shows an EF of 35%. We obviously offer that out, and the response is, can you repeat the echo in 12 hours? The echo's now 40%, heart shut down. It's frustrating because you look at other, UNOS or whatever, they take days. So are we rushing to the OR at the perhaps losing that heart? How long should we be waiting to say there's not going to be an improvement in that organ?
There will be an improvement. When you look at the natural history of these brain death caused cardiomyopathies, they will all recuperate. Sometimes it takes 2 or 3 weeks, though. That's the problem. We don't have the time, and usually the families are the ones that will put a stop to the process. And if you want to give us another 24 hours, we're always willing, always willing. We're not shutting it down on our side because of time. I mean, the more time we have, the easier it is to organize everything, the better prepared our recipient is. Unless it's a very unstable recipient, but then again, we would go ECMO and then maybe VAD eventually. But there's no time limit for us. We know they will recuperate, but very often we don't have the luxury of time. As I showed you, it takes on average 30 hours when you're trying to recuperate a heart. That's on average 30 hours. So some families have problems with, with this, and usually they are the ones shutting it down, not us, never.
I often find that if you approach the on-site coordinators, there's some here, when they approach and they explain to the families that this is a heart that we're trying to place, we're trying to give it, that it pulls a bit of an emotional string.
Right.
So I guess just from us logistically, should we wait another 24 hours, given donor stability, OR availability, team, all the recipients that are waited? So I'm glad to hear that another 24 hours would likely buy us some.
And you're touching another important point. In transplant, as I said, we're a kidney business. But when we want to promote, we take the hearts out. The hearts, it's different. It's more emotional, it's more sensitive. And I think some of the teams are saying, even if we wait and we're not going to take the heart, that's going to be such a heartache for the family. But again, have a stable donor, give us all the time you want. All the time, we're going to take it, don't worry.
Thank you.
Steve.
I had 2 questions, one for Jeff and one for Beatrice. Jeff, from a DCD point of view, I was intrigued that you've now increased your age limit up to 70, and I'm wondering if you could comment on whether that's an Ontario thing, whether that's going to be a Canadian thing. Was it driven by the fact that you get a wait list of 7 or 8 years, or is it driven by data that suggests that our chronological criteria was really not something we have to be quite as worried about? And for Beatrice, I'm intrigued about normothermic perfusion, especially in a geographic area where surgical resource is limited. How technically difficult is it to train people to get the cannulas in and get the process going? Does it have to be a transplant surgeon? Is it an emerge guy? Is it an ICU guy? From a technical sort of process point of view, is that something that is usable in a small peripheral center? Those 2 things I'm wondering about.
So when we initially had DCD criteria set at 65, we were kind of informed by our colleagues in the United States, and we started DCD in Ontario. That was kind of our hard cap, really based on what we'd learned from our US counterparts. And over the years, we recognized that, all donors were getting older, and we were having a lot of DCD and older ECD donors as well. And people started to say, well, why aren't we using these donors? And recognizing that a 70-year-old gentleman who jumps out of an airplane and forgets his parachute might be different than a 70-year-old gentleman with diabetes and hypertension. So people were starting to say, why not? We didn't actually have a lot of data to inform the change, but ultimately we raised the criteria, and we have some GFR criteria that I didn't show that goes along with that. And someone who's 70 or, for example, with diabetes and hypertension and vascular disease would probably not be considered. So it wasn't based on data, it was just based on starting off a bit more conservative, what we learned from the States, and then people were pushing for it, of course. That's what happened.
So regarding NRP, well, it has to be performed by a well-prepared team, a very well-trained team. It's not as expensive as, for example, looking at the excito preservation technologies that are being developed. We have calculated for every procedure it would be like 2,800 euros. So it's not a very expensive once you have the device, and it's less expensive than ex vivo or excito preservation technologies, which are really very costly. But NRP has to be performed by a very well-trained team. So at present, the composition of the teams who take care of NRP variable from one hospital to another. Usually the donor coordination team participates in that, since they always have an ICU physician who is familiar with this type of technologies. That's not an issue. In some centers, they take into account or they incorporate into the team perfusionists. So it depends. But what it is clear is that the team needs to be very well trained. It is a complex technique, and particularly in controlled DCD, it has to be performed very carefully and with a very refined approach. So you need to train the teams, you need to have a good composition of the team, but in terms of cost, once you have overcome those hurdles, the system runs well and it's not very costly.
Does cannulation in those cases occur prior or after death?
In controlled DCD, we can perform, according to our legislation on the autonomy of the patient, we can perform pre-mortem cannulation with a specific authorization of the legal representative of the patient with no mental capacity to give first-person consent. There are 11 programs which are using pre-mortem intervention with this legal authorization. And there is one program who is using the UK approach with a rapid laparotomy, clamping the aorta and including the abdominal cavity in ECMO postmortem with no pre-mortem cannulation. So we have the two models in place in Spain. In the UK, they are not performing pre-mortem cannulation, but they are now debating whether they are going to move forward into that direction as well. We still don't know what could be the advantages of pre-mortem cannulation. We anticipate it would be better because ischemia time will be decreased, but we don't have data yet to decide whether we could avoid the pre-mortem cannulation and strictly go to NRP post-mortem. What it is clear is that the surgical procedure evolves from being an emergent procedure in which the surgical teams have many times difficulties to properly recover and evaluate the organs, to a procedure which is more close to the DBD1, in which they can make a more post-surgery procedure. They can evaluate macroscopically the organs. The liver can be assessed in terms of the behavior of ALT and AST, and there can be a proper assessment inside of. So that's the potential advantage of the technique.
It has become apparent during the discussions this morning that we are pushing the envelope. One of the most disturbing signs I saw in Dr. Dominic Gill's presentation was beside the fact that they're the leaders in identifying and going forward with organ donation, there's still a growing disparity between those patients who need organs and those who do not get organs. So we are pushing the envelope. And an interesting phenomenon occurred with the inception of DCD. We started at an age limit of 60, maybe it was 55, I can't remember. So the cutoff was 60. So I was on call one week and I had a 68-year-old woman who collapsed while on a treadmill at her gym. of a cerebral aneurysm, and she was not brain dead, and so we withdrew care, and because of the age limitations of these organs. And I came in the next day and I was berated by our organ donor coordinator, saying, why didn't you suggest organ donation for this individual? And I said, well, the cutoff's 60. Well, Toronto last week transplanted organs in a 70-year-old, and the patient went home 2 weeks later, doing fine. So I think the difficulty here is communication. I don't ever want to become involved, and I'm speaking as an intensivist, making the decisions of what organs are good for transplantation. That's Jeff's job and the transplant surgeon's job. I don't want to be involved in that at all. I think our role as a critical care physician is to ensure that every potential organ donor is identified with no limitations from my perspective. There's no age limitations for any either NDD or DCD. We need to identify all potential organs and give the family, SDMs, even in the conscious, competent patient now, give everyone the opportunity to make that decision. So it's going to be interesting how we're going to match those patients who need organs. Living donation needs to be ramped up. I have a question for Dr. Cantin. You know, we do a lot of DCD donation now, more than NDD in our center.
No hearts.
One of the organs that we leave in the bucket is the heart.
Well, you know, the first heart transplant was a DCD. And the experience is kind of limited. There's been 3 of them in the US a few years back, but mostly in pediatric patients. Most of these patients, I don't know where you get them. I'm in a heart hospital, so of course when we go to a DCD, usually the heart is not that good, so we're not using them. But I guess eventually it will. There wouldn't be that many problems of doing it. It's just finding the proper organs to do it, because very often for the DCD, the heart is indeed one of the problems of the donor.